I think that we are ready to begin. Welcome everyone to the quarterly medical staff meeting. Once again, for obvious reasons, we're doing this virtually. Thank you for taking the time to attend. Our first step is always to approve the minutes of the previous meeting. This is obviously not, this format is obviously not conducive to this, but if anyone has an objection to the minutes, they can email me at my BJC email address, which is listed at the top of the agenda. The next item is the introduction of new medical staff members. For those of you new to this, new to the Missouri Baptist, typically we would be in a room and we would ask you to stand and introduce yourselves. Once again, obviously this format is not conducive to that, but I welcome everyone who's listening who sees one of these new providers to step up to them and introduce yourselves and make them feel welcome. We typically acknowledge or recognize a single provider at the quarterly medical staff, or sometimes two, who have stepped up and done exceptionally well for the medical center in the previous quarter. This month, I'm going to go a little bit farther and recognize all of these providers. What some of you may not be aware of, as we have all struggled with the pandemic, is that these providers have actually stepped up and done something more. In the Department of Medicine, we have, as well as in anesthesiology, we have providers who have stepped up and have worked in the intensive care unit. We have Department of Medicine providers who have functioned as hospitalists, Department of Anesthesiology members who have created a line placement team so that if someone needs a central line or something of that, like that, they are available to go do that. And we have a number of CRNAs that have cross-trained to be respiratory therapists. These individuals have sacrificed time with their families, have sacrificed their practices to step up and help the hospital during this pandemic and help our colleagues. And I believe they all should have special recognition for the efforts that they've done. So if you see any of these providers, I encourage you to thank them for stepping up and doing more than most of us have. They've done an exceptional job. Our next item is an update on vaccinations within Missouri Baptist and perhaps BJC at large, and I've asked Dr. Botany to present this information. Mitch, are you there?
Yeah, I'm sharing my screen. Can you see my screen now?
I'm afraid I cannot.
All right, let's try that again. I'm sure is yes, I'm sharing my screen. Is it coming through now?
I see vaccine update. Is that what you have?
Yeah. All right, so let's see if I can do this. This is not my screen. I'm not sure why I'm not seeing my screen up here.
It's not showing yet. It's not come through the queue. Let me stop sharing and see if that will help.
Yeah, you have to stop sharing, I think, for me to share. All right, let's try it again here. All right, is that showing up now?
Yes.
All right. And then, yeah. Okay. Is now can you see it? So
Yes.
I like to just start off. Somebody sent me this little text thing here about when we go into another lockdown, we'll just train all the Amazon delivery drivers to give the vaccine, and then we could all be immunized by next Saturday. But if you got Prime, you'd be immunized by next Wednesday. So I thought it was cute and maybe a way to make a point here that maybe we need to recruit some people who have done some amazing operational jobs in the past to help us with the vaccination process. But anyways, this is our current, some of our current statistics here. We're looking at, in the blue, BJC, and in the green, the total metropolitan service area. And these are the number of hospital admissions. And this is through January, I think January 9th. So you can see that overall, we are doing quite well with our admissions, and that we're not seeing the kind of turmoil that we're seeing in Los Angeles and some other places with their vaccination, with their admissions, and hopefully we'll continue that now as we start our vaccination program. There is a little bit of concern here. As you can see, our new cases was decreasing until around the holiday, and now we're starting to see some variability is how I would describe it in the last week or so. Whether this is reporting artifact due to the holidays or reflecting a true uptick related to the holidays itself and the social gatherings, it's not clear to anybody right now. So we'll have to just monitor this to see whether we continue to have an increase in new cases as this suggests, or that there's a reporting artifact with considerable variability here, as this graph could also indicate. Our projections based on current data was recently updated, and this continues to be the projections. The top curve is the most worst case scenario. The bottom curve in the light blue is the best case scenario. The projected most likely scenario is in the middle curve, and you can see with the black dots where we're actually falling in terms of inpatient census, reflecting the green curve that I showed just 2 slides back again. And this is ICU, which is perhaps more of the limitation that we see in the metropolitan service area, and that they're experiencing some of these other hotspots. And even there, we're doing fairly well, and we've not exceeded our capacity yet. We're not even close to exceeding our capacity in the metropolitan service area for ICU admissions. Vaccine, this is the state plan for vaccine availability. Phase 1A is what we're currently going through right now. The 2 groups of people who will be receiving vaccines at this point will be healthcare workers that are patient facing. Regarding that, the initial directive from the state was that these would be hospital-based patients, hospital-based hospital workers, hospital-based healthcare workers, but the state has now loosened that up, and anybody is eligible for vaccination if they are in a healthcare setting or seeing patients, whether that's private offices or in other locations. How that's going to be implemented is yet to be determined, but there are plans involved, plans being made at the present time to try and figure out how to operationalize, bringing people from a wide variety of locations and how to start their vaccinations. The other major group is the long-term care facility. The state decided that our allocation of the Moderna vaccine, which does not require quite the same cold storage as the Pfizer does, would be diverted to long-term care facilities for both vaccination of both residents and their staff. That is set to expire as the exclusive use of the Moderna vaccine on January 17th. Whether that means that there will be allocations of the Moderna vaccine to other healthcare locations besides the long-term care facilities is not exactly clear, and if so, how that will be implemented. I know there is active discussions between the state and the Missouri Hospital Association and other groups as to how to extend the vaccination program using the Moderna vaccine. Stage 1B is in the works to begin operationalizing as well. I know again that the state is actively planning on extending vaccinations to the phase 1B group. As you can see, that includes first responders, essential workers, as well as the high-risk individuals, and you can see the definitions of those in below the colored graphic there. This is a huge operational task, and I know that there have been active discussions again as to how to actually operationalize it. I was in a meeting on Friday where I found out that there are hospitals, the county hospitals for various rural counties in the state of Missouri that have not received any vaccine yet from the state, and they've not received their allocation. And so they're wondering how they're going to be able to provide these vaccines to their community when they've not yet received their allocation. So there's a lot of discussions going on, and it's very fluid. And what I say today may be very outdated by tomorrow or Friday. So we'll just wait and see how that's going. As I said, here's the current status of the phase 1. In the state, they decided that there were 500,000 phase 1A healthcare workers eligible to receive the vaccination. There are 366 vaccinating sites. There's 68 that are going through the process of becoming a vaccinator site, and there's a considerable backlog. You can see that there's still 258 providers that are still pending in the system. We are allocated roughly 420,000 doses of vaccine to the state. This is as of last Friday. Roughly 300,000 vaccines have been shipped. You can see the distribution between Pfizer and Moderna. As of Friday, 113,000 vaccines have been administered, and as of January 4th, that ranked us 15th in the nation. There, you can see that some hospitals, as I mentioned before, have received 0 to 25% of their vaccinations, and that really is closer to 0 than to the 25%. Some hospitals have received quite a bit of their vaccinations and have vaccinated quite a number of their healthcare workers. And I don't know what happened here, but I had one more slide just to go over where we stood with BJC. We are roughly at 42% of our vaccinations as of Friday. So some of that is due to what we were talking about in MBMC today, that there are people who are refusing their vaccinations. And the MBMC has voted to help with the discussion to help with people become vaccination candidates who previously refused. And but the efforts continue to roll out to vaccinate as many people as possible. And that's my report.
Thank you, Mitch. I neglected to mention at the beginning of this, for those in the audience, if you have any questions, for many of you, there's a button at the bottom that says questions and answers. You can enter your questions there, and we will answer them as time goes on or at the end. So please feel free to post questions if you have any. Mitch, I have a question, and I've raised this before. Do you happen to know if the hospitals are going to continue to serve as vaccination centers for the state? For example, will patients of the BJC Medical Group be able to come to the hospital and get their vaccine, or will they be going to an off-site location?
Chris, my understanding is that's still under discussion. and I don't have any details as to what the discussions, the details of those discussions, but what I've heard is that that's actively under discussion at this time.
Okay, thank you. Next on our agenda is Dr. Anand, who's going to speak to COVID within the hospital and provide us with an update. So Nitin, please go ahead.
Thank you. So Mitch went over some of this, but our peak ICU and inpatient census was on November 29th across BJC as well as at Missouri Baptist. And as you can see, the census has gradually decreased since then. We're down to 104 patients now. We had 46 critically ill patients in our ICU on November 29th. So we've, Missouri Baptist ICU census has been between 25 to 33% of this. Next slide. So despite the fact that the COVID ICU population has decreased, our ICU census has almost continuously increased since last summer. These are BJC's numbers, which show the ICU census increasing from 233 up to 345. Within Missouri Baptist, we've gone from an average daily census that was in the 20s pre-pandemic up to the 30s over the summer, and now we're consistently in the 50s. And this has happened because we've been able to increase our ICU capacity from 30 to 57 beds. We've essentially added 17 ICU beds at Missouri Baptist. Next slide. And these are some of our mortality statistics. I know some of this is numbing at this point, but we've admitted 1,500 patients to Missouri Baptist. 1,200 of those have survived, so 80%. And it's remarkable that our numbers are so close to BJC. We've had the highest proportion of transfers as far as our COVID volume across the system. So as you can imagine, transfers self-select for those patients with the worst outcomes. So the fact that 80% of our patients have survived is really a good thing. Next slide. So the science behind COVID has gradually evolved, as you all know. So some of these recommendations are constantly changing. What's been consistent since the summer, ever since the recovery trial came out, is we've been using Decadron for all patients who are hospitalized and require oxygen, and the thought is that decreases lung inflammation. Remdesivir has continued to be controversial. However, in the United States, it was approved by the FDA, and we've been consistently using it with the thought that it has some antiviral properties. And there was a randomized trial which showed that it decreases length of hospitalization, however, no effect on mortality. The data with convalescent plasma has also evolved. We had a paper in November that showed no benefit to convalescent plasma amongst all patients with COVID. However, recently, within the last week, there was a study which looked at treating patients who were just diagnosed with COVID. So patients who have only had symptoms for 3 days, and it had a mortality benefit. So the message with both convalescent plasma as well as monoclonal antibodies is use those drugs early. And monoclonal antibodies have primarily been being given in the outpatient world for that reason. It was shown to be able to decrease hospitalization. And I really think this is the most exciting area of science. We've never had antiviral treatments before, but I suspect with this monoclonal antibodies, we are going to increasingly see that kind of intervention in the future directed at viruses. Other immunomodulatory therapies are a great source of research. but none of them have really been shown to be of benefit above and beyond Decadron, so we haven't really been using them. And then lastly, prophylactic anticoagulation. There is a hypercoagulability state associated with COVID, and early on we saw many patients passing away with pulmonary embolism, stroke, and related complications. So the idea was to empirically anticoagulate. That's also fallen by the wayside, as we've recognized that while the risk is increased with COVID patients, it's really important to risk stratify the patients with testing. So it's evolved to, if someone decompensates, get a test, such as an echocardiogram or lower extremity Dopplers or a chest CT scan, and then decide whether or not to anticoagulate. Next slide. So lastly, we've been challenged by Scott Galloway's work at NYU to think about how COVID-19 has changed healthcare and the ICU. And he's come up with this term as COVID-19 being the great accelerator. What's happened is trends which were years in the making have happened in just a few months. So as an example, I think we're going to increasingly see more and more services move to the outpatient world. I think Mitch's slide about Amazon delivering vaccines is actually not that far-fetched. I don't think it'll be far into the future where people will be doing lab tests at home. As a result, however, and as a result of increasing technology, I think we're going to have more and more acuity in the hospital, and that's going to require more and more ICU care. Fortunately, as a result of the pandemic, the physicians and the nurses have had increasing experience with some of these technologies. We've taken care of a few ECMO patients now, which is something we weren't doing before, and I think we're going to increasingly see that. Lastly, the regional partnerships with BJC, as well as the transfer center, going to continue to evolve. Not every single health center within BJC is going to have the ability to have enough resources to take care of all of these technologies. So I think we're going to become increasingly dependent on the transfer center to be able to send patients to regional centers of excellence. And within BJC, there's only going to be a few of those sites. So I think as the ICU volume is going to stay high, we're going to need to respond as a medical staff on how we're going to be able to care for those patients. And that's going to be a challenge.
Thank you, Nitin. Just as a reminder, questions can be posted in the Q&A section. There have been a couple of questions posted already regarding vaccines, which Dr. Botany has answered. So please feel free to post your questions there. The next topic is one that I will be presenting. And I'm going to try to share my screen just because I want to, but it looks like I'm not going to be able to do that. Is anyone able to see my screen? No?
Not yet.
Can you see it now?
I can share for you if you would like.
All right, well, why don't we do that? So about 10 months ago, members of the Department of Medicine, Department of Surgery came together to address a problem that we saw developing at our hospital, and that was we felt that there needed to be a program designed to care for patients with complex cardiovascular needs. Now, like most areas of medicine, there is a high-risk subset of patients with, in this case, cardiovascular disease, who have most to gain from certain interventional treatments, but are often denied this care due to technical limitations, comorbidities, or risk. Now, to address this deficiency and to care for these patients, high-performing health organizations across the country have created collaborative team-based programs to leverage their specialized expertise and nuanced decision-making to achieve improved outcomes through the use of often complex, time-consuming, and capital-intensive treatments. And these have been primarily at academic medical centers. These programs, in the form that we're about to discuss, don't generally exist at community-based programs. Next slide. So the types of programs we're talking about are structural heart programs, which many of you have heard about. These have been designed to care for patients with congenital or acquired valvular heart disease or other structural cardiac abnormalities, usually utilizing both surgical and catheter-based techniques. But there is a second program that is not well publicized. These are called CHIPS programs, and that refers to complex, higher risk, and indicated procedures. And these programs principally are designed to care for patients with very complex coronary artery disease for whom surgical revascularization is not possible or appropriate due to comorbidities, anatomy, or other issues. Next slide. So in contrast to interventional cardiology programs, it's become clear across the US that successful structural heart disease and CHIPS programs require additional components. And most important among them is a collaborative multidisciplinary heart team approach to delivering care. This includes members from cardiology, cardiac surgery, anesthesiology, electrophysiology, radiology, and cardiac imaging, and also requires robust institutional resources, including facilities, finances, and personnel. Next. So at Missouri Baptist, historically, we've had a very high-performing but ad hoc program with exceptional outcomes that consists of members primarily from the medical group and Missouri Baptist Cardiac Surgery. It has worked very well, in part because team-based care is ingrained in our culture, but there is really no mandate at Missouri Baptist to care for these patients in this manner. And at Missouri Baptist, historically, clinical privileges to perform any specialized procedure was primarily granted based on the prior performance of a defined number of procedures in practice or training. Next slide. So a few challenges were identified early on in that we've had recently several community-based cardiologists who have applied for privileges to perform these procedures at Missouri Baptist, but the hospital has limited capacity to take on new providers. And the reason the hospital has limited capacity is that unlike many procedures, these procedures often require 2 to 4 physicians to be present during these procedures. It also requires exceptionally well-trained cath lab personnel, and there's only one hybrid suite where these procedures are performed. So this led to the question of how do you require a multidisciplinary team-based approach to care for these patients with complex cardiovascular needs from community healthcare providers when there is limited capacity to absorb new providers? And how do we mandate a team-based approach for these new providers? Next slide. So our solution was to create a program which we are at present calling the Advanced Cardiovascular Services Program. And it's designed really to collaboratively and expertly and efficiently care for patients with complex cardiovascular disease. It will include, under this umbrella, both structural heart and CHIPS procedures, and importantly, and this is a divergence from how things are normally done at Missouri Baptist, clinical privileges to perform these very selected procedures will just be restricted to members of the program. Next slide. So what have we done? Well, we've, because it is, this program is run under two departments, the Department of Medicine and the Department of Surgery, we have created an oversight committee that includes members of individuals that hold these positions, the Chief of Cardiology, the head of the cath lab, the medical director of structural heart development, the head of cardiac diagnostics, the chief of cardiac surgery, as well as ad hoc physicians and administrative liaison. Next slide. So far, the group has collaborated with the medical staff office to create and modify where necessary physician clinical privilege criteria for these procedures. We've created program membership criteria, and we've begun the process of approving physician members to join the program. Other important responsibilities that will be fleshed out in the coming months will be to create a process to review, approve, and adopt new technologies, enforce and create and enforce a culture of collaborative team-based care, align with the medical staff and hospital governance, identify research opportunities, and importantly, establish and maintain a quality metrics program. Next slide. So we think that there are certain advantages here of creating this program. It establishes requirements at Missouri Baptist to care for these patients in a multidisciplinary manner. For new providers joining the program, it secures their commitment to practice in this manner. It's been endorsed by both the MEC and the hospital board, and there may well be marketing possibilities for the hospital and the program as well. So that concludes my presentation. Again, follow the question and answer section, and we can bring items up. The next topic on our agenda is I've asked Dr. Thashara Mirza to present a project that is currently being worked on in the CEC. For those of you who are unfamiliar, the CEC is the Clinical Excellence Committee is a subcommittee of the Medical Executive Committee that was created to accomplish several tasks. The first was to provide leadership development within the medical staff, and also to identify and solve problems that affect our patients and the staff at the hospital. So I've asked Dr. Mirza to present the current status of a program that we're working on in the CEC, and I'll ask Dr. Mirza to take over. Thashara?
Yes, thank you, and thank you for that introduction, and good morning. I am one of the hospitalists here at Missouri Baptist Medical Center. I picked diabetes management as one of our quality improvement projects within the hospitalist group. But then I ended up reaching out to Kayla Wise, who's our diabetes educator, and Dr. Mitch Botney, and I was recruited to be part of the CEC project for improvement of diabetes here at the hospital. I wanted to give some background as to how diabetes affects Missouri Baptist Medical Center and all our patients, what it costs Missouri Baptist Medical Center, and how much time we spend on it, as well as the solution that we came up with. So just a brief background, how much diabetes cost how much diabetes care costs in the U.S. It's about $327 billion, and 43% of those costs are in hospitalized patients. Insulin is also a very frequently prescribed drug. 30% of errors involve insulin. Next slide, please. 5,100 patients here at Missouri Baptist Medical Center are prescribed insulin. We all already know how diabetes affects our patients. There's increased risk of MIs, myocardial infarction, stroke, renal failure, surgical site infections. But it also affects our patient outcomes. It affects healthcare costs, readmission rates. It increases length of stay. So why can't we get it under better control? Why can't we get diabetes care in the hospital under better control? Well, it's really very complex. And we've identified that Missouri Baptist has opportunity for improvement. Next slide, please. Just to give everybody a snapshot of what the current state in the hospital here is, and I'm sorry, these are the numbers from July to September. I don't have the numbers from October to December yet. The American Diabetes Association recommends that the appropriate levels of blood glucose management in the hospital is between 140 to 180. And as you can see, in September, for example, there were 5,913 events where patients' blood glucose levels were greater than 180. As blood glucose levels go up, patient complications go up. There were 806 severe hypoglycemic events and 240 severe hypoglycemic events. Next slide, please. This is a snapshot through the entire year. Each bar represents a month. As you can see, there's the number of patients and then how many of those were within the ranges that we were looking at. And if you were to look at the range of 300 to 449 blood glucose level, in November, there were about 228 patients with those numbers. That's really unacceptable, once again, because it increases the risk of patient complications. The complications that I mentioned, MI, stroke, surgical site infections. Next slide, please. So we looked at what the cost was. We know how it affects patients. What does it cost the hospital? We looked at central line associated bloodstream infections and catheter associated urinary tract infections. There were 19 CLABSIs and 24 CAUTIs, as we call it, and 12 patients within 2019 and 2020 had hypoglycemia, and 9 patients with catheter-related urinary tract infections had hypoglycemia. So what is the cost of these infections? Next slide, please. Next slide. Hello. Sorry, it looks like we're not able to get on to the next slide.
Maybe you could just describe it.
So here at Missouri Baptist, we calculated that just that number of infections cost the hospital about $570,000, and that's just central line associated bloodstream infections and catheter associated urinary tract infections. We haven't looked at how much surgical site infections cause Missouri Baptist Medical Center, and we haven't looked at well, what is the effect of length of stay in patients with hypoglycemic episodes?
So apologies, Shar, they're fixing the slides now.
Thank you. And then we looked at, well, how much time are we spending on blood glucose control here in the hospital? So the protocol here at Missouri Baptist Medical Center is if there's a blood sugar greater than 300 or a blood sugar less than 70, the nurse has to call the physician. So if you think about the nurse calling the exchange, waiting for the physician to call back, then having the physician call back and then put in the order, that takes quite a bit of time. And every time a sugar is abnormal in that range, there has to be a call put out. So we calculated that if the nurse spends 5 minutes and if a physician spends 5 minutes to deal with one episode that was abnormal, we end up spending, for example, in September, 174 hours just managing blood glucose control. And then we sort of thought about, well, how much would that cost? And came to the conclusion that 575 hours cost about $46,000 in physician and nurse care. So as you can see, diabetes has a lot of effects, and we wanted to figure out how to solve this. Once again, it takes quite a bit of time, and we wanted to figure out a way to, is there a way to automate glucose care? Because as Nitin said, patients are becoming increasingly complicated. And not only are we dealing with, just blood sugars, we're dealing with, a patient, for example, who has pneumonia and has renal failure and has elevated troponins, and diabetes is often an afterthought. So what if we automated it and, tried to help both physicians and nurses care for their patients better? Next slide, please. Kayla, our diabetes educator, was working on electronic glucose management systems as part of her master's degree. And we looked for, was there any information out there in the literature about electronic glucose management systems? And lo and behold, yes, there are multiple papers out there. We reviewed those papers and we reached out to the authors. There was Dr. Aloy at Wake Forest and Dr. Ulal at the University of Pittsburgh, who were supportive of electronic glucose management systems to manage our patients with diabetes. We looked at demos. There are two out there, EndoTool and Glucomander, that have both sub-Q insulin and IV insulin, and they're automated. And then we made best practice calls. There are 300 hospitals in the US that use electronic glucose management systems. We also met with Dr. Rilpu, our endocrinologist, to put forth this idea, and came to the conclusion, next slide please, that Glucomander is the electronic glucose management system that would work well for us here at Missouri Baptist Medical Center. Why? Well, it does not impede our workflow. It reduces the average time to reach glycemic target. It automates insulin titration. It's FDA approved, and it follows ADA's, that's the American Diabetes Association's best practice guidelines. So how does bringing in a glucose management system to Missouri Baptist Medical Center align with our values? For that, we looked at the white paper for Missouri Baptist Medical Center. So MBMC's vision talks about enhancing patient experience, bringing forth programs that focuses on the continuum of patient care, and delivering highly specialized care in an advanced care setting. And this electronic glucose management system fits all of those criteria. So we made the presentation with the help of Dr. Botany to the foundation here at Missouri Baptist Medical Center, and they approved, they kindly agreed to fund the program for a year. We wanted to pilot it here at Missouri Baptist Medical Center. We then met with the upper echelons of BJC's EPIC system, so Dr. Dick Taylor, Tracy Jones, Dr. Jeffrey Sislow, we did meetings with the vendor, and currently this is undergoing a vetting process. We're waiting. I'm told the process would take a few weeks. If they approve, then we would be able to implement the system hopefully as early as this summer. That's my presentation. Any questions?
Thank you very much, Tushara. We will again, ask people post questions in the question and answer section. I don't think that that is working particularly well because I think some of those have been answered privately at the end. I'm going to ask the presenters to stay, and I will ask them online here to answer some of these questions so that those that are listening can hear the responses. Our next presenter is John Antes. He's going to provide us with a picture of how the hospital has done during COVID. So John, please, it's all yours.
Thank you. And I'm going to try to forego using any slides myself. So, first off, I want to thank all the medical staff. I know it's been a difficult year for you. I think everybody involved has had their own journey through this, and I don't think anybody's journey has been without a lot of change in their lives and difficult. But all I can say is I am extremely grateful to have this medical staff as a partner. The leadership of the medical staff has been unbelievable. The partnership has been unbelievable, and just it's one of the things that I'm grateful for every day when I come to work is the wonderful medical staff and the wonderful leaders of the medical staff that are at MOBAP. So Chris did ask me to talk about how the hospital is performing. And so, there's a lot of different qualitative ways that you could think about how we're performing, and you experience that when you're here. But it is, we have 5 different areas that we look at, kind of categories that we look at, and how we determine, are we being successful in any given year? There's thousands of metrics that we track in hospitals across between quality, patient experience, finance, workforce, all of that. And we try to boil that down to literally, it's probably about 100 metrics that still go into the roll-up of how we're performing across these 5 different venues. The 5 different venues are clinical quality, patient experience, our workforce, our talent, how are we doing financially, and then we call it activity, but really we look at it as growth. As you know, as an organization, if you're not growing, you tend to not be faring well. So we're always looking for how we're going to grow. So I will start with clinical quality. Clinical quality, a lot of you have heard this is BIC, our best in class scorecard. There's literally, I think, 25 different things that we have identified that we measure. And those roll up into 6 kind of key areas. And we roll them up with a score of anywhere from, we could be at a 0 in a year, we could be all the way at 150. Target is to be at 100. MOBAP this year is at a 99. So we're right at target. And what does target mean? Target means for these metrics, we're in the top 15 to 20% of hospitals in the country. To give you a perspective, how did that look last year? We were at 113 at this point in time during the year. So we're down just a little bit. That difference between where we were last year and where we are this year is pretty consistent when you look across BJC and performance at hospitals, and our performance is a little bit above the overall BJC performance. So we should be proud of that. There are some areas that we've struggled a little bit with this year that with the number of COVID patients we have and how we take care of those and access to those, it's a little bit more challenging in a few of our preventable harm areas to maintain real strong performance in. Patient experience. Patient experience is actually based upon what we consider the questions that our patients answer about their overall clinical quality or overall quality of care. So that's a perception. It's not a real one, but it is how the patient perceives their quality of care. And we're compared to a database of several hundreds of hospitals across the country. And we are right now, we're at a number, the scoring number, the highest you can get is like 100%. We're at 74.4% top box. That means 74.4% of our patients rate us excellent for their perceptions about our overall quality of care. That firmly puts us into the 90th percentile. That's probably around the 92nd, 93rd percentile. Comparing that to last year, we were 72.2%. So our patient sat has went up. And what's interesting, I think a lot of people felt like this was going to be an area from a status with performance that we were going to struggle with this year, given the changes with COVID, the lack of access that families have to their loved ones to be able to come in and out of the hospital, those kind of things. But there is obviously, we have done a great job across our team during some really challenging times. I know they're tired as they can be, just like you are. But I also think it goes to show that our patients continue to be grateful for all of you being here to take care of them during these trying times. Under the workforce end of it, we really primarily look at turnover. We have other metrics, but we really focus in on turnover. And we look at overall turnover, so it's turnover across all the employees in the hospital. And then we look specifically at our RN turnover. And so this year, we are at a turnover rate of 15.1 for all of our employees. How does that compare to last year? We're up by about a percentage point. Last year, we were at 14.1. Our RN turnover is at 15.2. Last year, they were at 15.4 at this time. So our turnover is actually a little higher than what BJC's turnover is on average by about a percentage and a half point. So there's some work that we can do in there as we move forward. The next thing is the financial performance. And I know a lot of people giving financial reports before to the QMS, and a lot of the doctors, when we did it live and everybody come to the same room, there were ones that I think were wanting to leave about the time I started this. But the last ones we did seemed to get a lot of interest in. I will tell you, I feel like whether it's quality, whether it's our people, or whether it's finance, I believe we're connected at the hip. If you look at how we are across the board as physicians and as a hospital, how we are viewed by the payers, what their expectations are of us. And if you look at the integration that's happening between the medical staff and the hospital, we are more and more linked together financially. So this year, what I can tell you is both our finance and our activity, our growth, those metrics are probably our worst metrics we've had since I've been at BJC, which is about 15 years. If you're looking at them year over year, I'm not even going to talk about the activity ones, the growth, because we're negative in all of those. We're red in all of them because of some of the shutdowns we've had to do, as you would guess. But operating earnings, we are through November. Now this is without CARES dollars, okay? So we do have some subsidy dollars that'll come in on top of this, but we won't book those until we close out December. But through November, we are at a $254,000 loss for the year. That's the first time I've ever seen MOVAP at a loss position for year to date on operations. Last year at this point in time, we were closer to about a $40 million bottom line. So keep in mind the money that goes to the bottom line, that's the dollars that we use in order to reinvest in capital equipment, to reinvest in salaries and wages, to reinvest in all the different programs that we have across the hospital. So it's important for us to maintain a healthy, reasonable profit. We measure something else called unit cost. Unit cost is simply, if you think about it, if you last year somebody came here and they had a colonoscopy done, and the average cost for that could have been $100. This year, I realize it's a lot more than that. I'm just using that as an example. This year, if they came and had one and it was $105, that would tell you my unit cost change was a minus 5%. So our costs went up by 5%. And the reason why we monitor this, obviously, we know the entire country is interested about the cost of healthcare. And we are also limited, if you think about it, we're limited on what we see in payer changes in rates of reimbursement year over year. The federal government obviously doesn't give us 5% increases year over year. But our unit cost this year is a minus 5.5%. Last year it was a minus 0.8%. So year in, year out, we try to get that to average about 2 to 2.5%, no more than that. If it gets above that, we start to outstrip the reimbursement adjustments that we tend to get year over year. We have two more that I'm going to go over and then I'll be done. We have something called labor per stat, and labor per stat is very similar to unit cost, but it's not measuring the cost of labor. It's measuring how many hours it takes us to to do certain things. So just like I used the example as a colonoscopy, you know, if we had a $100 cost and it went to $105, last year, if it took us 10 hours to do a work time all in between all the different people to do a colonoscopy, and this year, if it took 11 hours, that means our labor per stat would have been a minus 10%. We were 10% worse on our productivity level. And why is that important? Well, it's important because of our overall cost in the hospital, 40 to 45% of that is labor. And so we're always looking to try to make sure we're managing our productivity at a reasonable level. So we're at a minus 2% this year in labor productivity, which is not bad. It's actually, I think, pretty daggum good, given the fact that our volumes have been way down and we have had to staff a lot of incremental people to take care of COVID patients. I think that's pretty daggum good. And then just to wrap it up, our supply expense last year ran us a little under 28% of our net revenue. So for every dollar we brought in, we paid out 28 cents on supplies. This year, we're paying out around 29 cents on supplies for every dollar we bring in. So those have went up just a touch. And I think as a percent of net revenue, some of that is really due to the fact our revenue has shifted this year and the types of things we're doing. So we've seen some shift in that metric, meaning as we shut certain things down and we had, you know, higher cost in other areas, it shifted some of that that percentage level. And so that's what I would tell you overall. I think it's a pretty good scorecard when we look at it. And when I kind of adjust it, we're coming out, you know, we're doing well on clinical quality. We're doing well on patient experience. We need to work on our overall turnover. Our RN turnover is doing pretty well. And as you could guess, we are not doing well on the financial metrics, but we're in better shape than I thought we were going to be after the end of the first part of the year, quite honestly. So,
okay. Thank you, John. So we have a few moments left to answer some questions. Many of these were answered privately, but they may have interest for the broader group. And I will ask Dr. Botany to address the first one, which is, what is going to be the role of the primary care physicians when it comes to risk stratifying their patients and determining where they fall in getting the vaccine? Has that been determined?
That has not yet been precisely determined. There is a role for the PCP, but the question is how does the insight that the PCP has regarding their patients get translated and communicated to the vaccination program? And you can imagine the operational difficulties with that, given the number of PCPs that we have and the number of patients involved in each one of their practices. And so I think we need to, we're going to need to figure out how to operationalize their contribution and their insights. And that I can tell you has not been even addressed in even a rudimentary way. Okay. So that's something we need to work on.
Another question related to vaccines is the Group 1B didn't mention cancer patients or immune compromised patients. Was that an oversight? Or is that what are your thoughts on that?
Well, that determination is made by the state, and I don't know what their deliberations were when they made that list up. I would suspect that that was more of an oversight than a deliberate exclusion, just based on what we know about these kinds of patients.
And there's been another question regarding treatment for outpatients that need monoclonal antibodies. How does a physician refer a patient into that program? What is the process for that?
I think everybody now in BJC has access to the EPIC ordering system. Now, I don't remember exactly what the EPIC order terminology is, but there is an order within BJC, within EPIC, that will allow you to order a monoclonal antibody infusion. That infusion is being done at Sunset Hills as well as some other locations around the region. But the closest one is the Sunset Hills. I can tell you that that infusion center is working very well. We just got a email last week from Nathan Moore, who had a elderly patient who had met qualifications for getting an infusion. That is, they were not on oxygen and they had less than 3 days of symptoms. So they were early cases and they were outpatients. He entered his order and that patient within about 3 hours was already in the chair getting their infusion. So I just sent out a link, and in MedStaff News, which is going out this week, there is also an article which will give the link for any further questions. And if anybody, I will try and find the exact order nomenclature so that we can send that out to everybody so that they know where to find it in Epic.
Okay, thank you, Mitch. Thashar, there's been a question regarding sliding scale insulin, and I think the broader question is, and perhaps you can share this, is how will tools such as Glucomander limit the number of calls that the provider gets regarding insulin management?
So once a provider decides to use Glucomander, it's basically an order that you click. The program takes over the glucose monitoring and deciding how much insulin the patient receives. So there's no other input from the provider. What the nurse does is in the program, which seamlessly integrates with Epic, she puts in the patient's blood glucose levels, and the program gives the nurse a recommendation on how much insulin to give. It also tells the nurse when to check the next insulin, when to check the next blood glucose level. For example, if it's a patient with a blood glucose level of 250, and it tells, or well, I'll use 300 because that's the metric that the BJC system is looking at in all its hospitals. So if a patient's blood glucose level is 300, the program would tell the nurse to switch to, maybe IV insulin, give a dose of 10 units, and then check the patient's insulin in an hour or in 2 hours. And then so the nurse follows those instructions and takes care of the patient that way. So it's all between the nurse and the program. The provider really does not have to do much. So it saves time that way, because in our current system, the provider has to be called every time the blood glucose is greater than 300. But with this system, that does not happen. The nurse does not spend time looking for the provider to get orders. And that's how it basically works.
Okay. Thank you. That seems to address all of the questions that have been asked. I want to thank everyone for attending. I'm sorry we ran a few minutes over. Next quarterly medical staff meeting is in April. I anticipate that it will be virtual as well, but perhaps later this year we may be able to meet in person. Again, thank you for attending, and I hope you all have a pleasant week.
Thanks, Chris.